Okay, the next case that we're going to do is a 2-year-old who's brought to the emergency room for evaluation of altered consciousness after falling off the bed. If we look at our history, we have a 2-year-old boy who's brought to the emergency room by his mother for evaluation after falling off the bed several hours earlier and sustaining trauma to the left side of his head. The mother is an 18-year-old single parent who did not complete high school and has a part-time job to support her child. The child was at the babysitter's the day before and spent time there when the mother's boyfriend is busy. The boyfriend occasionally helps with the babysitting and was with the child when the injury occurred. The child was delivered via normal spontaneous vaginal delivery, and the mother had sporadic prenatal care. The newborn and the mother left the hospital within 3 days, and the child was formula fed from birth. If we look at developmental milestones, they're appropriate for age, with a height and weight being at the 40th percentile. The 18-month booster immunization was lacking due to an ongoing viral illness, as related by the mother. She last saw the pediatrician when the child was 20 months for an acute respiratory illness. The mother states that her boyfriend told her that while asleep, the child rolled over in bed and fell off. The mother was not present at this time. Now, this should be a red flag for you. As soon as you hear that the patient had a fall and it was from a bed, we shouldn't be expecting such a bad injury. So we need to be thinking, what's the physical exam going to be showing? Because you have a single mom who has multiple caregivers, a babysitter and a boyfriend who help her with the child, and she may not be always there to witness what's going on. The bed was about 2.5 feet from the floor, and the child hit the ground on the left side, making contact with his left arm, head, and flank. The boyfriend told the mother that the child cried immediately and was easily consoled. Okay, so there was no loss of consciousness, which is important. The mother arrived home about 3 hours after the incident to find the child asleep in the bed. When she asked about feeding, her boyfriend stated that the child didn't have formula for the last several hours. When the mother went to try to wake the child for feeding, he was barely arousable. At this time, the emergency medical services was called, and the child was brought to the emergency room for further evaluation. The mother denies any history of prior trauma and is hesitant to answer questions related to her relationship with her boyfriend. Physical examination shows the child to be very quiet and lethargic. Okay, now this is key. You have a child who had been previously healthy, previously normal, mother's not home for a little while, comes back, and she can't wake her baby up. You have to be thinking, is this child abuse? Why is this patient who had a fall? Is this trauma? Why is this patient who had a fall suddenly lethargic? No acute respiratory distress is noted. The child is not responsive to verbal stimuli. There is a left temporal hematoma, 5 by 4 centimeters. The right arm also has an ecchymotic area, and the right upper quadrant region shows an old resolving bruise. So now you have to think to yourself, the patient only fell off 2.5 feet. How did they get injured so seriously? Because we have people who fall off second-story balconies that don't have as many injuries as this patient. And why does the patient have an old bruise? Especially in a place where it's not easily bruised, the abdomen. The lower lumbosacral area has several areas of mild yellowish discoloration and transverse linear distribution. So now you have something that's a pattern bruise. So this should also raise your suspicions for abuse. The fact that it's yellow in discoloration makes you think that it's old. Because remember that in order to assess child abuse, in order to assess any abuse, even in geriatrics, you need to know the staging of bruises. So remember that on the first day, the bruise is red or purple. The second to third day, it turns black-blue. The third to fifth day, it turns green. The fifth to seventh day, it's yellow. So this is a minimum of 5 to 7 days old. And after that, it starts to fade and is flesh-colored. The skin turgor appears good, the sclera are anecteric, and the conjunctiva is pink. If we look at the further exam, if we're looking into the fundi, we see a retinal hemorrhage at the 3 o'clock position. We know that although not pathognomonic for child abuse, because there have been occasional instances that retinal hemorrhages can occur, that this should raise a red flag for child abuse with this particular story until proven otherwise. The oral mucosa seems to be moist, and the TMs show no evidence of bleeding in the canals. If we look at the neck, it's supple. He does have a right-sided cervical abrasion noted, but there's no adenopathy. The lungs and the chest show decreased respiratory effort with shallow respirations. Cardiovascular is within normal limits. If we go to the abdomen, we'll see that the patient has minimal response to palpation as far as becoming alert or becoming aware of pain. He has possible right flank discomfort with palpation, and in the lower lumbosacral area, he has again several areas of yellowish discoloration as described. There are no masses in the genitalia. His extremities show again some bilateral infrapatellar minor abrasions. Otherwise, the significant finding is that there is an ecchymosis on the right upper extremity. Neurologically, you've got a lethargic child. He's not responsive to verbal stimuli. His pupils are reactive to light bilaterally, but they appear to be sluggish. The deep tendon reflexes are present bilaterally, but they're somewhat decreased symmetrically. Now, we're saying that this pretty much leads us to child abuse. However, other things in your differential diagnosis that you need to be thinking about is this lethargic child septic, or do they have meningitis? Was this truly an accidental injury? Highly unlikely with a fall of 2.5 feet from a bed, especially if it was carpeted, but you should consider it. Does this patient have rickets? Does this patient have any other kind of congenital noteworthiness, such as a Mongolian spot? If you had discoloration in the sacrogluteal area, it should be, if it was Mongolian, it should be slate gray. It shouldn't be yellow. Remember that if you didn't know the difference between a Mongolian spot in the sacrogluteal area, which is a birthmark, versus a bruise, you would see that the Mongolian spot will not change color. All right? Does this patient have any hematologic problems? I once was in the emergency center and a mother walked in with a child who looked like he had been hit by a truck. And she said to me, "Arrest me." I said, "Excuse me?" She said, "Arrest me. I will go to jail if you can tell me what is wrong with my child." She said, "I haven't been going to the doctors because I thought you would think that I beat my child up." But she said, "This is not normal. My baby just touches the corner of a table and he looks like we've beat him or that he was hit by a car." And she said, "If it means that I have to go to jail while you're working him up, I will." It ended up that we diagnosed that this patient had a new onset of hemophilia. So you need to be thinking about other potentiating factors for child abuse. Other things, again, under miscellaneous are physical child abuse, and this is probably where we're going with this case. So you do your initial diagnostic plan. And it's important for you when you're suspecting child abuse or you see bruising that you be able to prove that this was not secondary to any other abnormality, such as von Willebrand's disease or hemophilia or, osteogenesis imperfecta. So in this particular case, a CBC with differential would be helpful. You want to also look at platelets because the ITP, or idiopathic thrombocytopenic purpura, can also mimic child abuse. It looks like the patient is bruised or has red marks. The platelets that aren't there are helping the child develop petechiae. The other thing you want to do is check the prothrombin time and the partial thromboplastin time. Look at the bleeding time. Make sure that the liver is functioning by ordering LFTs. You want to be thinking about amylase and lipase, especially in physical abuse, because you want to see if there's any damage to the pancreas. Other things that you want to look at, a urinalysis. Why? You're going to order that to look for blood, okay, hematuria. You want to get a creatinine kinase. You want to make sure that you look at your electrolytes. And that in this particular case, if you could only do one diagnostic study, it would be the CAT scan. Because this person has retinal hemorrhages. This person is lethargic. This patient has altered mental status. This person has a high probability that they have a bleed in their brain. So you do the WBC count, and it's 12,600. 73% are neutrophils, 20% are lymphocytes, and your platelets are within normal limits. You do your PT and PTT times respectively, and they're also within normal limits. You look at your liver function test, again, within normal limits. And so far, all the tests that you're doing are within normal limits. Your urinalysis does not have hematuria. You find on the CAT scan that the patient has a subdural hematoma in the left temporal region, but the patient has no midline shift. This is pretty much what you most likely would have suspected, because once you see retinal hemorrhages, you need to be thinking, was this patient a victim of the shaken baby syndrome? And what does that mean? Well, it means that sometimes the parents are so angry that they start shaking the baby. And you know that a lot of times our babies don't have that good a head control, and so their heads are just bobbing and bobbing and bobbing. And eventually they're going to do a big slam, and the slam onto a mattress, onto a floor. And you're going to get a coup-counter-coup effect in that respect, and you're going to end up usually with a subdural hematoma. All right? So you need to have a high suspicion. All right. So what are the risk factors for child abuse? Okay? The main risk factor of being a perpetrator or a person who abuses children is having been abused yourself. If you look at the history that we read, we said that the mother was tentative to give us any information on what her relationship was with the boyfriend. The question is the mother also a victim of abuse? All right? The next thing that you want to be thinking about, what else could place you at risk if you were a potential child abuser? Well, if you have a patient or a child who may have been premature, you may not have had an opportunity to bond with the patient. Or if the child had special needs, if they were handicapped, they might have put an extra stress on the family, financially, emotionally. All right? And we're not saying that every premature or handicapped patient is going to be a victim of child abuse, but we're thinking about life stressors that could contribute to being a perpetrator, being someone who abuses children. We all know that child abuse crosses all socioeconomic status. However, if you don't have money, a lot of times you can have added stress in your life when you have to buy shoes, you have to buy clothes, you have to buy food, you have to pay the rent. All right, so that might set you up. Other things that might set you up is if you have an extraordinary or an exceptional child. What do I mean by that? Well, besides having a special need as far as a health problem, what if you had a child that was a genius? All right, somebody who would like to take the vacuum cleaner apart and figure out what was going on. If you had a dad or a mom who would prefer him to be playing baseball, to them, this child didn't fulfill what their expectations of having a son or having a daughter was. And so, in their mind, this child might seem odd. And so that child might get picked on or be set up for a victim of child abuse. The other thing that you want to think about as far as your case is that this particular case, the mom did not have really reliable child care. At times she had a babysitter, at times she had the boyfriend watching. And we're not, again, sure what this boyfriend relationship is with the mom. Your child is also here behind in immunizations. And although not much behind, it still raises a red flag when you're thinking about what kind of care does this mother give the patient. Is this mother not only forgetting immunizations, maybe they're not doing something else. Maybe the child doesn't have a proper diet. Maybe the child, isn't clean. And you might say to me, well, how is that abuse? But all things that go into nurturing and developing the child to its fullest potential have to do with our care. And if we're neglecting this, although not physical abuse, it may be a neglect or there may be an emotional abuse. Other things that we want to be thinking about, as I said, you always want to make sure that if you go to a court of law, that you can prove that there was no other medical problem. And you're going to say, oh, Dr. Kerner, I want to stay out of the law, especially out of the courts. And we all do. But it's our responsibility as healthcare providers to be mandatory reporters. Now, that doesn't mean that you have to step up to the plate and nobody is going to tell you that you're going to court or whatever. You might get called to court, but you remain anonymous until something is founded, okay? So, for instance, if I sign a sheet that says I suspect child abuse, I give it to the proper authorities. When they go to tell the mother, they don't say, oh, Dr. Kerner wrote something against you. You remain anonymous until they can discover if what the problem was true. Personally, it's better to tell the parent up front that it's my responsibility as a physician to report any cases that don't seem to match the history with the physical exam. So I'll say to the mom or the dad, I'm not accusing you. I'm sure that you want what's best for your child. But this just doesn't seem to be right. And by law, I'm obligated to report because maybe someone is actually hurting your child. And the best example I can give is a patient that I had that had a square mark on his back. He had been left with a grandmother and the grandmother's children. And when I asked the mother, well, what's this all about? The mother said to me, oh, he got burnt in the shower. Well, this is a square box. This was something hot that was in the shape of a square, a pattern bruise, pattern burn. And I said to the mother, this can't have happened in the shower. And she kept saying to me, don't accuse my family, they love my baby, etc., etc. I took a cup of water and I threw it against the wall. And I said to her, this is what a burn in a shower would look like with the water as it dripped down. I said, you wouldn't get a square. And suddenly, the mother's eyes just lit up. She called her family and said, what did you do? And, we had to have that high suspicion of abuse. All right? And they had burnt the child with probably the iron, but without the triangle part. Okay, so just the bottom of the iron hit the child. All right, now, what else do we need to be thinking about here? The patient had an increase in liver function test, and this actually suggests abdominal trauma. We know that the patient must have had some abdominal trauma because you need to remember from your history that the patient had an old bruise on his abdomen. Other things that we need to be thinking about is the subdural tells us that the patient must have had an infliction onto his head. After this, they're going to ask you what's the next step. Because this is a young patient, less than 5, you need to do a skeletal survey. The skeletal survey will give you the maximum amount of information in children 2 or less. All right? However, we still use it in less than 5. If we suspect child abuse in a 10-year-old, we're not going to do a skeletal survey. And the reason not is, 1, it's a lot of radiation to the whole body, and 2, those children usually will tell us or be able to communicate with us who the perpetrator is or was. Where a 2-year-old is not that verbal. And so we really will do the skeletal survey to see if there are breaks in various bones in various stages. Now, in this particular case, it showed several areas of bony injury, including a healed left rib fracture and a right arm metaphyseal fracture. A patient should not have a rib fracture that's this age. And falling off the bed isn't going to cut it. All right? And so, again, another red flag. The treatment plan following this would be neurosurgical consult and drainage of the subdural hematoma. Okay, again, our diagnosis would be child abuse. Subdural hematoma is a secondary diagnosis. We have discussed some of the risk factors of being an abuser. We've also talked about some of the risk factors of being abused. And then remember that the physical findings are usually not consistent with a history. That should be a red flag. And that if you were going to have a cause of death from physical abuse, if that was a question, it would be head trauma. Remember, if you're less than 6 months and you're being physically abused, you have a very good chance of being killed. Remember that, again, fractures and bruises in various stages of healing are red flags. Pattern bruises, such as burns, bites, intra-abdominal injuries, retinal hemorrhages, should be looked for. Again, we've talked about the tests that we needed to do if bruising was present. We've discussed our bone survey in children. We've talked about samples of urine. We also should get a sample of the stool and test it for blood, especially if we've had abdominal trauma. And again, you are a mandated reporter, and all cases suspicious for child abuse should be reported. I can tell you that I had attended a conference here in New York, and one of the faculty had said that there was a case at his hospital where a physician who was a community physician had been following a 12-year-old boy since birth. He was very good friends with the family. The family was very affluent. And the young man came in with a broken arm, but the history didn't match the physical exam. The doctor thought, well, this could be child abuse, but because he had known the family for 12 years, because he had established a relationship, he just made a small note in the chart to himself. Next time I see the patient, I should check for flags for child abuse. What happened is that the patient never got a chance to come back the next time, because probably about 2 to 3 months later, the doctor gets a subpoena for his medical records. And why is because this young child was beaten with a baseball bat by his parents. Now, in every state in the United States, it's some type of penalty. Misdemeanor, either A or B, where you have to pay a fine. Some people, your license is suspended for X number of months, years, whatever. So they see right there, they go to the doctor's records and they see his little note, because they wanted to see compliance. Did he have his shots? Had he been followed at the doctor? What did the doctor note on the body? So this man, of course, was suspended, and he had to pay a fine. The parents, of course, went to jail. However, the parents in civil court sued the physician for $1 million because they said that they would not have gone to jail had the doctor done his job, because he's a mandated reporter, and number two, that their son would not have been so hurt, and they sued the doctor. So I hear you say that that's absurd. It is absurd. But the idea is, you know what you're supposed to do. Now, the doctor who was giving the lecture said he didn't know what the civil court had decided. But because he had already said he was guilty, and it's obvious that he is by law, there would probably have to be some exchange of money. But the doctor who was giving the lecture suggested that instead of $1 million, only $1 be given. All right? So I don't know the outcome, but remember, don't try to help, don't try to cover up anything, because if you do what's right, everything will work out to the best. All right? Just remember for subdural hematoma that you have a crescent-shaped hemorrhage that's compressing the brain, which would be noted on CT, and that you would need evacuation. And some complications that you can get from a subdural are neurological deficits and death, and also uncal herniation. If a child had sepsis or meningitis, the patient may have had fever. There was none in this case. The patient may have been ill prior. The patient was not in this case. Again, the patient may have had a bulging fontanelle, none in this case. Remember that for meningitis, older children complain of headache, neck pain, photophobia, and emesis. If you have sepsis and meningitis, you also can see lethargy, which our patient had. You can also see bruises. Bruises and fractures in various stages would not be present. If you did have meningitis, the one key diagnosis in order to make that call is a lumbar puncture and looking at the cerebrospinal fluid. Remember that your treatment for meningitis would depend on the type of organism that you suspected. And we said this morning that if you suspected a neonate to have meningitis, that it would be group B strep, Listeria, and E. coli as the organisms, and that you would use the therapy of ampicillin and gentamicin, or ampicillin and cefotaxime. If you have an older child, the three organisms that you need to worry about are Neisseria meningitidis, Haemophilus influenza, and also you need to worry about a patient having pneumococcal strep, or strep pneumoniae. All right? And for that particular case, your next step would be that you should treat with ceftriaxone. If you had an accidental injury, the history would match the physical exam, and you should not delay in seeking medical help. If you saw old healing fractures, pattern injuries, bruises in various stages, that's not accidental. Metabolic, we're thinking about rickets. This is caused by deficiency of vitamin D. With those particular people, you would have frontal bossing. You might have thickening of the wrist and the ankles. The patient may have a history of having knock knees. And they may have developmental delay in standing and in walking. Again, don't forget your congenital hallmarks, the Mongolian spots. We get gray birthmarks, usually found in the sacrogluteal area. They will not change in color. Osteogenesis imperfecta can sometimes be confused with child abuse. However, there's a triad, and the triad is blue sclera, early deafness, and fragile bones. So if you see blue sclera, fragile bones, and early deafness, then you need to be thinking about osteogenesis imperfecta, even if the story sounds like child abuse. If we look at other disease entities for our review, Henoch-Schönlein might also appear to be an abuse. It's a vasculitis. You'll get lots of small vesicles that are affecting the skin, causing petechiae and purpura. It's a palpable purpura, and it's usually distributed on the buttocks and the legs. Again, we talked already about idiopathic thrombocytopenic purpura, and the physical exam would be absolutely normal, except for some bruising and petechiae. Remember that they're going to have very low platelets, so it's going to set them up for bruising. Remember also that the person with ITP, or idiopathic thrombocytopenic purpura, will have an excellent prognosis, and that your treatment may include intravenous immunoglobulin to increase the platelet count. And steroids are useful in severe cases only. Now, sometimes what happens is a person might have leukemia, and they come in and they look bruised. However, They may have other things that tip you off: splenomegaly, petechiae, mucous membrane bleeding, low-grade fever. They might complain of bone pain. This is another patient that you can put into your limping category. They might present with a limp. So think of the child who has leukemia. Again, hemophilia, the deficiency of factor VIII may lead to excessive bruising. However, you would have some abnormality with your PTT. However, your platelet count would remain normal. If you did have hemophilia, like the patient that I told you about who came into my office, you would use replacement factor VIII, and also if the person had hemophilia B, you would use replacement factor IX. Sometimes in the hemophiliacs, we use the DDAVP to increase factor VIII. The one thing that you want to remind your patients, and you want to make sure on the exam, that you avoid aspirin and that you avoid any antiplatelet medications. In this big differential of child abuse, we also include von Willebrand's disease. Remember that this group of individuals have a prolonged bleeding time. There may also be a history of a patient and family members, which would help you make this particular diagnosis. All right? So your PT and PTT would be normal, but your bleeding time would be abnormal. And this would help you make the diagnosis of von Willebrand's and then go on to manage your patient. Again, your treatment would be with fresh frozen plasma and DDAVP. And this will lead us into our next case, which is a case of a patient who has fever and a rash. Okay, you have a 3-year-old boy who has a 6-day history of fever up to 100.4 Fahrenheit. He also has irritability and a rash. The patient for the last 24 hours has had diarrhea and vomiting after eating. He is non-cooperative and irritable. His heart rate is 140 beats per minute, which is about normal for this 3-year-old boy. Might be a little tachycardic. He has a low-grade fever that might contribute some to this, and he might be a little dry. Physical exam shows bilateral conjunctival injection, fissured lips, a strawberry tongue, and diffuse injection of the oral and pharyngeal mucosa. There is tender cervical lymphadenopathy present. Cardiovascular examination reveals tachycardia, a normal rhythm, and no murmurs. His lungs are clear, his abdomen benign. There are swellings of his hands and feet with a reddening of the palms. Neurologically, it's focally within normal limits. The differential that we need to be thinking about here is Kawasaki. All right? You've got a person who comes in with fever, swollen palms, swollen feet, and red palms. You need to be thinking about Kawasaki disease. Other things that you might think about are viral myocarditis. You might have a patient who has Stevens-Johnson syndrome. The patient may have some cracked lips, some conjunctivitis. You might have a person who has leptospirosis. Post-streptococcal disease might be considered in this differential diagnosis. You might have somebody who has a toxicity to a drug. You might have infantile polyarteritis nodosa. Or you could have juvenile rheumatoid arthritis. So what are you going to do as the manager of this case? First of all, you're going to get a CBC with differential, and you're going to look to see if there's any evidence of infection. This patient certainly has leukocytosis of 30,000 cells. The H&H hematocrit is 32%. The platelets are 350,000, which are within normal limits. The other thing you're going to do is look at a urinalysis. The urinalysis is pertinent for proteinuria. You have in this particular patient, a history of a fever lasting more than 5 days. You have conjunctival injection, oropharyngeal changes, peripheral extremity changes, a polymorphous rash, and cervical lymphadenopathy. These are all principal criteria for Kawasaki syndrome. Now, if we think about what Kawasaki is, it was discovered by Dr. Kawasaki in Japan, probably in the 60s. We honor him by calling it his name. However, the generic name for this is mucocutaneous lymph node syndrome. So what you need to know, if you can't remember all the criteria to make a diagnosis of Kawasaki, that the patient always has a fever greater than 104, 105 Fahrenheit for 4 to 5 days. The secret here is there is no source, so you can't have otitis media. You can't have meningitis. You can't have anything else with it, okay? So fever without a source, high. What else do you have? Mucous membranes. What's wrong with them? Well, first of all, I am going to have a strawberry tongue. I may have cracked lips. My conjunctiva are conjunctivitis, but non-purulent, all right? What else is going on? Cutaneous. What's wrong with my skin? I've got swollen palms, swollen feet, red. Think about it. If I don't get diagnosed for a week, I'm going to have subungual peeling. My skin is going to peel at the fingers. All right? But that's a late finding. But you're going to probably find it late. What else do you need to be thinking about with the skin? It has a typical appearance of a scarlatiniform rash. Nobody knows really what causes Kawasaki disease, but they're thinking that there's an association between strep and staph. Therefore, you need to consider it if you see this scarlatiniform rash with a strawberry tongue. You're going to say, well, this is just too confusing. How am I going to know that that's not scarlet fever? Because the buzzwords in scarlet fever are strawberry tongue, circumoral pallor, Postia's lines, which is a prominent rash in the creases, and this macular-papular red rash. So that's how you're going to be able to know what your next step is, because you're going to be able, by the buzzwords, to differentiate between Kawasaki and scarlet fever. All right? So we've done mucous membranes, cutaneous, we've talked about, and then the last part of that was lymph node syndrome. Okay, that's what we said Kawasaki was. What's wrong with the lymph nodes? Well, in Kawasaki, you usually have one unilateral cervical adenopathy. If a patient had scarlet fever, what is scarlet fever? It's a sore throat and a rash. You'd have bilateral cervical adenopathy. So that's how you're going to be able to differentiate. All right, and so basically your lab tests are supportive of the diagnosis, but there's really no time to wait. Okay, because you also know that in Kawasaki, the later it gets, after about a week to 10 days, the platelets may rise to 1 million. Okay, they're not going to give you everything in this particular scenario. So if you could only do one diagnostic study, it would have to be an echocardiogram. Why? What's the problem with Kawasaki? You can get coronary aneurysms. So you would want to check to see if you had coronary aneurysms. If you do not see a coronary aneurysm, you are not out of the woods. As a physician, as the primary caregiver, you must then institute therapy. If you could only choose one thing as the next step, it would be intravenous gamma globulin, IVIG. However, if you could choose two things, two steps, it would be IVIG and high-dose aspirin. All right? And then the other test may be helpful, the SED rate, you would want definitely an EKG to look if the person is having any myocardial infarction or any arrhythmias, etc. But if you had to choose the best is the echo. All right? Now, on our particular patient, it shows a slight pericardial effusion with a small coronary aneurysm. Your SED rate is 40. You've got, on an EKG, prolonged PR and QT intervals. You have an abnormal Q wave and low voltage ST and T changes. There are some other findings: elevated C-reactive protein, alpha-1 antitrypsin, and hypoalbuminemia. So our final diagnosis is Kawasaki disease. And if, again, we look at the case review, we've gone through Kawasaki. And if we look at our other considerations that we had in our differential diagnosis, viral myocarditis, how the story would change is that there would be inflammation of the myocardium. We know that this is usually caused by adenovirus or Coxsackie B virus, and so there would be probably a history that the patient had some type of viral illness. The most common presentation would be heart failure, which is not what we have in this particular case, and this would clue you in to a viral myocarditis case. What test would you order if you had viral myocarditis? Well, first of all, a chest X-ray, EKG, echocardiogram. You'd want to look at viral titers and polymerase chain reactions. If you needed the one test that would confirm the diagnosis, it has to be an endomyocardial biopsy. All right? So when you're taking your examination or when you're working with patients, think about what do you want and what are they asking for. Your treatment would be management of heart failure and any arrhythmias. As far as viral myocarditis, if the patient has refractory heart failure, the only way to go would be with transplantation. Without treatment, the prognosis for this viral myocarditis is poor. What about Stevens-Johnson syndrome? Didn't they say that one time they had some kind of problems with their mucous membranes and cracked lips? That's why they put this in the differential. All right? Yes, they have a rash that shows like erythematous macules, and it has central necrosis, and they'll end up forming vesicles and bulla, and all of a sudden their face will look denuded and sloughed, and they'll have problems with their trunk and extremities. Remember that there's lesions that can occur on the mucosal surfaces, and that because they're sloughing skin, they're losing fluids. So you need to make sure that you're giving back those fluids. Other things that you want to be sure of is that these children would be at high risk for superinfection. Now, what would set you up for having the Stevens-Johnson syndrome? If you had mycoplasma pneumonia, or if you took drugs such as sulfa, say we had a patient that had otitis media, and we gave trimethoprim sulfamethoxazole, we might see a Stevens-Johnson from that. The NSAIDs and phenytoin have been associated with Stevens-Johnson. The treatment would be supportive and symptomatic. The only time you're going to give antibiotics would be if the patient had suspected sepsis or if there were skin infections or urinary infections. What are other things in your differential diagnosis with Kawasaki? The other things might include leptospirosis. Remember that this would be an infection with spirochetes, and that there are occupational risk factors that go with this. Usually exposure to rat-contaminated water or soil is a risk factor. Remember that how does the spirochete get into the body? And it would be through abraded skin or mucous membranes. Again, most of your cases of leptospirosis will be subclinical. They may run into liver or renal problems and also meningitis. Again, remember that the most useful screening test is this slide agglutination test, but it's now becoming replaced with ELISA and dot-ELISA test. Other things that you need to know or you would be asked or requested would be the treatment. And you would want to give the patient penicillin intravenous or tetracycline, orally or intravenous, if the patient was allergic to penicillin. What about the post-strep disease? That can sometimes also be confused with the patient who has Kawasaki. Why? because a lot of times they have a history of a sore throat. They have a history of their tongue looking funny, the strawberry tongue. They may have a history of cervical adenopathy. If I had post-strep disease, though, I might present with an acute nephrotic syndrome, or I might end up having gross hematuria, edema, hypertension, and renal insufficiency. Remember that this disease usually follows the throat infection by about 2 weeks, 1 to 2 weeks. However, if you have a child who is 3 or less, the chances of those children having strep infection is very minimal. Usually, if those children had throat infections, it was secondary to a virus. Therefore, unless you know they had a direct exposure, maybe another family member, probably in a younger child, less than 3, this would be very low on your differential diagnosis. The key would be to see red blood cell cast in the urine, and the diagnosis would require that you had evidence of a strep infection with a DNase B antigen study. Remember that the reason that this would be so important is you have a throat infection that now has caused you to have glomerulonephritis, and so you're worried about renal failure. So what would be your goal of therapy or your goal of management? It would be to treat renal failure and to give antibiotic therapy with penicillin, which would be indicated. Okay, and then the recovery, though, from this particular disease would be good. What other things did we say could be thought of with the Kawasaki disease? Well, we mentioned infantile polyarteritis nodosa. Remember that this is a necrotizing vasculitis. It affects small and medium-sized arteries. We don't know what causes it, but we think it's a post-infectious autoimmune response. It usually peaks around 10 years of age. Your child here in your exam is 3. And what we're worried about is aneurysm formation. Again, your diagnosis, if they asked you this next step, would be a biopsy or angiography. But the first thing that you might see is that the SED rate, the erythrocyte sedimentation rate, may be elevated. How would you manage this particular case? You would have to give oral or intravenous steroids, and if there was any detect if there was any vascular compromise in the extremities, and give a prostacyclin analog. So was there any thrombus formation? What would be the complications? You would see skin ulcerations, high blood pressure, and again, coronary arterial disease. You could have a mild to severe case of this, but if you have multi-organ involvement, it can result in death. And that will bring us to our next case, irritability, malaise, and abdominal pain.